Forget frequently asked questions.
Common sense, common knowledge, or Google.
How about advice from a real genius? 95% of people in any profession are good enough to be qualified and licensed. 5%
go above and beyond.
They become very good at what they do, but only
0.1%
are real geniuses. Richard Jacobs has made it his life's mission to find them for you. He hunts down and interviews geniuses in every field: sleep science, cancer, stem cells, ketogenic diets, and more. Here come the geniuses. This is the Finding Genius Podcast
with Richard Jacobs.
Quick note before we begin, the Finding Genius Foundation, as part of the Finding Genius Podcast, has recently completed a book about understanding viruses. So the creation of this book was to interview 100 virologists, ask them a lot of deep, difficult questions, take the most difficult questions, and then re-interview the top 25 or so and ask them the hardest questions I could think of. And we compiled that all into a book. So you'll see question and 4 or 5 experts' answers. Question, 4 or 5 experts' answers. There's about 30 questions in the book. I think it's a great read for the layperson and for the researcher. It talks about a lot of speculation in the world of viruses, such as are they alive or not, and why is it important? Why do viruses go latent or hidden or ineffective or sit in a person or an animal or another creature for weeks, months, years, and then suddenly become virulent and affect that person? So there's a lot of really provocative questions in the book. It's now on Amazon. So if you go to Amazon and type in Finding Genius, you'll see the book on viruses. It's also on Kindle. The Audible version is in production and should be ready in approximately a month. But if you want to go and order it now, you can do so again by going to Amazon or Kindle, or go to findinggeniusfoundation.org and go to publications. There's an opportunity as well to get the transcripts of all the interviews and to hear the original interviews themselves. If we put them all together, the book would be about 1,000 pages, but we condensed them down to make it juicy and concise and tight and very interesting. So I hope you'll check out the book. We're now working on one about cancer, but this is going to be our goal is 3 times a year to come out with these masterclass books that I think will inspire new scientific research, and I hope you'll check it out. Thank you.
Hello, this is Richard Jacobs with the Finding Genius Podcast, now part of the Finding Genius Foundation. You may want to go to Amazon and check out our book on understanding viruses. Just type in Finding Genius. This was a book created by interviewing over 100 virologists and then re-interviewing a top 25. I think the book has a lot of super interesting concepts in it. So again, check it out on Amazon by Finding Genius. Today, my guest is Dr. Rabia Bhatti. She's a breast surgeon at West Suburban Medical Center and the medical director of the River Forest Breast Cancer Center, or Breast Care Center. We're going to talk about her work. So Rabia, thank you for coming.
Most welcome, Rich.
Yeah, tell me a little bit about your history. How did you end up being a surgeon and why a breast surgeon?
Well, I'm thrilled to be here today. You know, I think I was meant to be a surgeon. As I tell my students, I think I was born a surgeon. I was always thrilled by the surgeons who were being portrayed in the media, or I could read their autobiographies. And so I wanted to be part of this cadre of people who will, touch patients and actually put their hands in the patients and remove diseased organs. So that's what sort of piqued my interest in the beginning. And then when I went to medical school, I just loved operating and being in the team of people who actually ends up giving really rapid cure for our patients. But as I evolved as a general surgeon, I realized that I wanted to not just cure patients by taking care of the diseased organs, but also I wanted to be a healer. I wanted to take care of the whole patient. And so I started spending more time with my patients, which is, as you know, a little uncommon with surgeons. We, like to kind of do things quickly and then move on. But I wanted to be a surgeon who will also be a healer for our patients. And that made me sort of concentrate my work in breast cancer. And so I'm now taking care of breast cancer patients.
How long have you been doing surgeries, and what have you noticed? What has changed over the years with the type of surgeries you do?
Okay, so I've been in practice for about over 20 years as a general surgeon and then as a breast surgeon. And in the beginning, when I was in residency, we would be taking a lot of our patients to the operating room for even making a diagnosis of breast cancer. So that has changed remarkably over the last 20 plus years, that now we are doing minimally invasive biopsies in our office. So which means, less discomfort for the patient. We are able to give them a quick diagnosis without putting them through a major surgery. Also, we have now started seeing this change in the way we used to think about breast cancer. In the beginning, we used to think about breast cancer as being a surgical problem, that once a surgeon comes in the picture, the breast cancer can be cured. But actually, we know that the surgeon is only one small cog in the entire wheel of the treatment for breast cancer. And so breast cancer is now a multidiscipline process. And so we cannot work in isolation and take care of breast cancer patients alone. So that's been another change in the breast cancer treatment. And then also in terms of the surgeries themselves, we are now trying to do more cosmetic surgeries, less mutilating surgeries, performing more reconstructions, offering more options for patients to preserve their breasts rather than performing mastectomies or removal of their breasts from the get-go. So we have become now more minimally invasive, but also becoming more comprehensive in terms of how we are providing care for our patients.
Yeah, I guess many years ago, the breast removals for cancer were incredibly, like, crazy radical. They would take out the breast and a lot of the underlying tissue and the muscle and everything, right?
Yes, absolutely. And those were called the radical mastectomies, where we would remove the breast and the tissues in the armpit. We would remove the muscles. And so it was very deforming. You would, get this scar, which would be kind of concave. It would be, you could see the patient's ribs and the chest wall, and surgeries are very painful also. But now we are doing more and more of skin-sparing mastectomies, where we save the entire skin overlying the breast and just remove the breast and the nipple and the areola area. Or we are doing what's called nipple-sparing mastectomies, where we don't remove any skin or nipple, but we just remove the entire breast tissue. And all these advances have been made possible by the use of, obviously, instruments in our operating room, which are more lighted. We have lighted retractors, we have headlights, and our devices that are used for cutting the breast tissue are more friendly for the skin, so we don't end up burning the skin as much. So it's been these advancements that have led to these amazing surgeries that we are doing nowadays. And obviously, we are offering reconstruction to most of our patients, which means that they end up getting immediate breast reconstruction at the time of the mastectomies.
Okay. Yeah, in the days when they would do like these radical mastectomies, cancer would still come back with certain people.
Yes.
And now that you're being a lot less invasive, do you still get the same level of clinical outcomes? Is it better? Is it worse, or the same?
So this is one thing we actually figured out about 30, 40 years ago, that cancer cannot be treated by surgery. The reason that patients would die or the cancer would come back on the chest wall is because the biology of the cancer was such that we were not really going to be able to cure it just with the surgery. So with the advent of chemotherapy and radiation treatment, and now that we are going into even genomics, which is looking at the genes of the cancer itself, we have seen now that our survival rates have improved remarkably, because we are able to catch cancer at an earlier stage and then treat it with different modalities along with surgery.
So even though it's a lot less radical, a lot less invasive, the outcomes haven't suffered at all, which is good.
Yes, absolutely. And so that's the fun part about surgery. Now we can tell our patients, you're going to be living for a long, long time. And as you know, there are many millions of survivors, breast cancer survivors now, who are living in with the history of having had breast cancer. So that's really hopeful for our patients.
Is there any need for surgery at all? I mean, I know it's a weird question, breast surgery, but if radical didn't work, if, less invasive is working to the same level, like, has anyone tested doing other modalities of treatment, but no surgery at all?
Exactly. So that's a very good question. And we actually have seen now, based on our clinical experience, that patients who receive chemotherapy, who have certain kind of cancers, so certain cancers which are, HER2 positive. So as you know, all cancers are not alike. So we are talking about specific subset of cancers where we can give them chemotherapy and immunotherapy prior to surgery. And when we go in to do the surgery, there will usually be no cancer left behind where cancer used to be present. So that has led us to start some clinical trials and to see if this will obviate the need for any surgery with the use of these multiple modalities. But we don't have any clinical trials right now on invasive cancer, but there are trials going on carcinoma in situ, or the early stage 0 breast cancer, where they are trying to see if surgery can be avoided and the patients can be treated just with hormonal treatment or radiation, etc. So we are waiting for the trials to come around. And I think this will be probably not in my lifetime, but, afterwards, I'm hoping that surgery may not be necessary in all the patients.
Before we continue, I've been personally funding the Finding Genius podcast for 4.5 years now, which has led to 2,700 plus interviews of clinicians, researchers, scientists, CEOs, and other amazing people who are working to advance science and improve our lives and our world. Even though this podcast gets 100,000 plus downloads a month, we need your help to reach hundreds of thousands more worldwide. Please visit findinggeniuspodcast.com and click on Support Us. We have 3 levels of membership from $10 to $49 a month, including perks such as the ability to see ahead in our interview calendar and ask questions of upcoming guests, transcripts of podcasts you're interested in, the ability to request specific topics or guests, and more. Visit findinggeniuspodcast.com and click Support Us today. Now back to the show.
Well, what do they call the time between the resection and cancer coming back? Is it called like a latency period? And, with these less invasive surgeries, has that period changed length at all?
Right. So you're talking about their 5-year survival. So we are looking at cancer, in terms of 5-year survival generally, or 10-year survival. And using all these modalities along with our surgery, we have been able to reduce the recurrence rate, which means the chance of cancer coming back, and have improved the survival rate. So now with the early stage breast cancer, which is stage 0 and stage 1 cancer, which hasn't spread to the lymph nodes, the 5-year survival could be anywhere from 95 to 99%. And then, it goes for localized cancer, which is staying in the breast and in the lymph nodes, the survival rate is about 86%. So it has improved over time since the, advent of all these other modalities.
Again, 5-year survival, it sounds like, do I live or die after 5 years? But, let's say after a resection is done, at about 1.5 years, I'm just making this up, that, they do a test and cancer will either come back or not, typically. Let's say the average length is 1.5 years. Has that changed since the days of the radical work versus now?
Cancer is not the same. As you know, there are many different kinds of cancers. So the cancers that are called hormone-positive cancers, they usually come back much later. So not at 5 years, but sometimes at 10 years, even up to 20 years. So that time obviously is much longer, as opposed to cancers which are called triple negative cancers, which don't have any hormone receptors on the cancers, or are HER2 positive cancers. These cancers have a risk of coming back, the highest risk within the first 2 years. But then if it doesn't come back in 2 years, then the risk goes down over time, as long as they had treatment. So the latency period, I guess you're saying, between the time that you complete treatment and of cancer coming back has increased based on these other modalities that we are now using for treatment of breast cancer.
Well, that's good. So it's all positive. So it's less invasive. The latency period's longer. The outcomes are better. So it's all good so far.
Oh, absolutely. I mean, this is, as I tell my patients, it's bad that you have cancer, because most of my patients do have breast cancer, but I'll say it's the best time in our lives to have breast cancer, because we have such excellent treatments available and the prognosis is so good. So, as long as we follow through with the treatment, we will have an excellent outcome. Obviously, every case is different, so I cannot give you one number for every patient, but on average, our survival and our recurrence rates have gone down.
And then in terms of mammography, I've heard that some women have dense breast tissue, so they need to have, I guess, an MRI instead. Like, what are the nuances of mammography and how has it changed?
Okay, so, as you said earlier, I am medical director for the breast program at River Forest Medical Center. So we just had a new mammography unit installed in our building, and it's called the 3D Hologic Genius Unit, and which has been now approved by FDA as being superior to the traditional mammography units for detection of cancer in dense breasts. So dense breast means that the breast has more fibrous and glandular tissue as opposed to fatty tissue. And women between the ages of 40 and 50 have about a 50% chance of having dense breasts. And in the dense breast, the chances of missing a cancer is out of two patients, you may miss cancer in one of them with the dense breast. So that's a pretty significant issue. And, in 2004, there was a PhD student in Connecticut by the name of Nancy Capello, who was given a clean bill of health. And then 3 weeks later, she was found to have stage 3 breast cancer.
If you like this podcast, please click the link in the description to subscribe and review us on iTunes.
And she made it her life mission to start informing patients and physicians about the breast density. And because of her, we were able to have a breast density notification laws passed in over 30 states, including in Illinois in 2019. So any woman who has dense breasts, which are called heterogeneously dense or very dense breasts, will end up being eligible for getting either a 3D tomography or an ultrasound or an MRI. So we usually start with an ultrasound and then go on to an MRI if it's needed. And I always tell my patients, understand your breast, know your breast density, because a lot of our patients don't know that. So that's the way you take charge of your health, by knowing that you have dense breasts. And if you do, then you request your physicians to order another additional testing for you. And it should be approved by the insurance companies. So thank you.
Well, what happens in ultrasound where it doesn't work and you have to go for MRI? What governs that decision?
Okay, so mammography, as you know, is based on X-ray. So X-rays are cutting through the breast tissue, giving you slices, and you look through those. But when you have dense breasts, then the X-rays don't work, and so we use ultrasound or sonography to determine if there's anything in the breast tissue. Now, sometimes patients have either a very strong family history, or they've had prior cancer, or the breast tissue is such that even on ultrasound, you can't really tell what's going on. In that case, we would recommend an MRI. So what we do is we calculate every single patient's risk of developing breast cancer based on what's called the Tyrer-Cuzick score. So it's a score that looks at multiple factors, and I wouldn't bore you with all that, but involving, family history and various questions about their age at the time of their first periods, if they've had children, etc. And using that number, we decide if a patient should get an MRI, because if their lifetime risk of getting breast cancer is more than 20%, then they will usually get an MRI along with the mammogram. By the way, an average woman's risk of getting breast cancer in the United States is about 12%, 12 to 13%. So if that's
pretty high.
Yes, that's pretty high. But if it's over 20%, then the MRIs will be recommended.
Oh, what kind of early screening goes on to see which tranche of risk you're in? How risky you're, what do they look for to establish that?
Okay, very good. So that's where what we do is we have high-risk clinics where we start screening women at a much earlier age based on their family history. So you start with the family history because that's the only tool we have right now to determine if patient is higher risk for getting breast cancer. And then, we have these patients come in and they see, a physician who deals with high risk patients. So like I do high risk counseling for these patients. And so we will determine, what are their risks. We give them a score. And then based on the score, we will decide if they need imaging earlier than the required age of 40 and above. So we may even start imaging at an earlier age, depending on the family history and their risk score. And this imaging helps us detect cancer at an early stage. Also, we tell these patients about what are the other lifestyle risk factors that they can change to reduce their risk, which includes exercise, which has been shown to reduce the risk by even 30%, changing your diet, avoiding red meat and sugar, and trying to eat more cruciferous vegetables, more of a Mediterranean diet, can reduce the risk of breast cancer by 30%.
What's the incidence of breast cancer in women that have dense breast tissue versus not? Has that been tracked?
Yes. So that women who have dense breasts have a 2 to 4 times higher risk of breast cancer than women who have normal density breasts. And so that breast density is part of that Tyrer-Cuzick model I talked to you about. That's put in the breast density is part of that model, and that's included in the score to determine the risk for breast cancer.
And you also mentioned, obviously, there's many different types of breast cancer, HER2 positive, et cetera. Mm-hmm. So what does that risk profile looks like? In the population, you said, I guess, on average, about 12% will get breast cancer, but what percent tend to have HER2
Positive breast cancer?
Positive, or triple negative, like how does that break down?
Right. So I'm going to give you averages here, depending on who you read, but about 15 to 20% of patients can have HER2 positive cancer, and about 10% of patients can have triple negative cancer. But the risk of triple negative cancer goes up in African American women to about 20%. So 80% of cancers are what we call the hormone-positive, estrogen-positive cancers. But these others, so the HER2 positive cancer is an aggressive cancer, but as I said, the percentage is still lower than the hormone-positive cancer.
And what about in women with dense breast tissue? You said they're more at risk, but are they more at risk for a particular type of breast cancer or just overall?
That's a great question. I don't think that has been studied yet. So to date, we don't really think that the breast density relates directly to the subtype of breast cancer. But that would be a question probably that will be answered in upcoming trials, but we don't have that data yet. We haven't seen that anecdotally that patients who have dense breasts have a certain kind of cancer versus the fatty breast. So
it'll be interesting.
Yes.
What sites in the breast are the typical nucleation or starting sites for cancers? And again, does triple negative tend to occur more in the ducts of the nipple versus the breast mass or vice versa?
Okay, so again, this has not been studied extensively, but we do know that, so there are two kinds of cancers or two kinds of tissue in the breast that you should be aware of. There's the ducts and the glands where the milk is produced, or lobules. So there's lobular cancer and there's ductal cancer. So lobular cancer is the less common, as about 10 to 20% of patients may have lobular cancer. And lobular cancer is generally not triple negative and not HER2 positive. So it's usually estrogen positive cancer. So the ductal cancers are the kind that are usually triple negative and HER2 positive.
And what about women that have given birth and breastfed? They look for correlations there. Is that protective against breast cancer or not?
Yes, definitely. So if you look at the risk factors for breast cancer, and a good resource for that is the American Cancer Society. They put out a lot of information about it. We have found out that women who have children or have a full-term pregnancy before the age of 30 have a lower risk of cancer than women who have children after 30 or have never had children. And so about breastfeeding also, so the World Health Organization recommends that women breastfeed for at least 6 to 12 months, and that has been found to be protective against breast cancer.
Okay. So what big mysteries are you looking at with breast cancer? What are you trying to figure out?
Right. So as I told you in my story, I was a surgeon. I've been operating, and so I've been doing the surgery part, but now I'm trying to get into the role of lifestyle, of your nutrition and your exercise in preventing breast cancer, and in women who are diagnosed with breast cancer, how exercise can actually treat their cancer. And so that's becoming my sort of passion, and I'm trying to read a lot about it. And then I do lectures to my patients and the community about this, because I believe that this is, a significant part of the treatment of breast cancer, and that is not really being emphasized traditionally up till now. So that's why I actually did a fellowship in integrative medicine from University of Illinois with Dr. Andrew Weil, so that I can learn some of the skills that are needed to educate my patients about the role of the lifestyle in the treatment of breast cancer. And there was a study that came out, actually, it's really interesting. It was published in Cancer Journal in May 11, 2020, that showed that women who were exercising 2.5 hours a week, which are the federal guidelines for exercise, had actually a 60% lower risk of dying of breast cancer, and had a more than 50% lower risk of cancer coming back, which is a tremendous number. And so we are now, I'm using exercise as a treatment modality for my patients. And I spend time in my office while we are talking about surgery to emphasize exercise. And I will have them start exercising even before their treatment is started, just to help us, prevent cancer and prevent the cancer from coming back in these patients.
Have you talked to them about dietary intervention, fasting, intermittent fasting, again, ketogenic diets, things like that?
Exactly. So, I'm not a dietitian, but we screen all our patients who who have a heavier weight. So we know that women who are heavier with a higher BMI have a higher risk of cancer recurrence, of cancer coming back. And so we will refer them to a dietitian. Our dietitians are generally talking to them mostly about the Mediterranean diet, which is an easier diet to follow than the ketogenic diets, which are, concentrating more on the fat. And so they're harder to comply with those diets. So we recommend the Mediterranean diet, but obviously if a patient's interested, then we can do the ketogenic diet too. Intermittent fasting, we usually don't recommend while we are starting treatment for breast cancer because, we do need patients to be optimized in terms of their, nutrition and their protein status, et cetera. So we don't want them to be, and hydration. So we don't want them to get dehydrated. And also we will talk about intermittent fasting after they've completed treatment, or we'll talk about it as a prevention for breast cancer, because women who do intermittent fasting do have a much lower risk of developing breast cancer, and studies have proven that.
Well, have you ever taken films, before you do the surgery, they do some kind of intervention, exercise, diet, et cetera. And then when you get in there to do the surgery, the tumor mass is a lot smaller or different or disappeared. Have you observed that?
That's a good question. I'm not working in, research right now. I did do research during my residency and prior to that, but that's a interesting question. So exercise and breast cancer is a topic that's been studied extensively. And right now it's being studied in women who were getting chemotherapy for breast cancer. And they found that they had the higher, survival rate and a lower recurrence rate. But I don't think the effects are immediate, not as immediate as chemotherapy is. So I think that it's more of a longer term effect than chemotherapy.
And what about, so you're the surgeon, you've seen countless tumors. When you get the pathology reports back, does that correlate with what you see? If the tumor looks a certain way, is a certain shape, does pathology tell you a similar story? What do you observe?
Yes. So, a surgeon has to have an understanding of radiology and pathology, because eventually when we go in to remove the tumor, we need to make sure that we remove it completely. So when we look at images with our mammography colleagues, we will then in the operating room try to correlate that with what we see. But remember now, most cancer, it will not be visible to the naked eye, because nowadays in the United States, over 60 to 70% of patients have early stage or stage 1 breast cancer. So that's not visible to the naked eye. So we will sometimes use ultrasound to help us. But eventually, once we remove the tumor, it's sent for pathology, and then we review those cases in our breast conference where we will be given, will be shown the images. And usually they correlate really well. The radiology images will show us a similar picture as the pathology slides. And then eventually when the specimen is cut by the pathologist, they'll show you a similar picture. So the cancer doesn't usually, try and trick us. There are certain kind of cancers which can be more insidious, sort of harder to find. And those are the invasive lobular cancers, where you may not form a mass, where the cells are kind of all spread out through the tissue. And then in that case, we may get surprised when we remove that tissue that we don't have a one tumor mass and there's, multiple sites of cancer, or the margins are positive. So invasive lobular cancer can be a challenge for us in terms of making sure that we remove it completely because of the way that it behaves. It doesn't form a mass. It kind of has isolated cells stuck together, not like a mass.
When you look at the morphology of the tumors that you take out, for HER2 or triple negative, does it look different? Do they tend to have certain morphologies depending on the type of cancer?
Right. So usually the triple negative cancers are more aggressive cancers. So we call them and they're usually grade 3, which means that the nucleus kind of has a pathology. And I'm not a pathologist, but I'll tell you that it'll be looking more like a undifferentiated cell, which hasn't really formed a certain histology. So you'll see more aggressive features, like there'll be more mitosis, which means cells are growing at a fast rate, or there'll be, invasion of the tissues, etc. So the triple negative cancers are more aggressive in that way. HER2 positive cancers can also be grade 3. And so you will see a certain morphology, which will, tell us that this is a more aggressive cancer.
Yeah, when you look at the the tumors you take out, how do they look versus the normal tissue? Do they look like completely aberrant or
Yes.
slightly different?
So again, it depends on obviously the stage of the cancer. So if the cancer is early stage, we may not see anything with the naked eye, but when they cut it, then they will see these, strands of sort of fibrous tissue along with this cancer cells going through the tissue. So there are certain, pathologic features that tell us if it's cancer or not. And sometimes if it's a higher stage cancer, then I can tell, because when I cut the tissues, then I feel this hard, gritty tissue under my knife. And then I know that I'm cutting through cancer, and I'll make sure that I take out extra tissue to make sure that I get clear margins. But in early stage cancers, generally, you don't get that kind of feel with your instruments or with the naked eye.
Well, is the breast a popular place for cancer to metastasize, or no, is it usually a site of primary tumors?
It's usually a primary tumor, but the cancer can metastasize anywhere in the body. Invasive lobular cancer can go to, anywhere, literally anywhere. Even I've seen it go to the scalp also, the skin of the scalp. It can go to but then it can also go to the lungs and the bone, liver, even the abdomen, etc. So cancer can metastasize anywhere, especially the breast cancer. But generally, you don't get metastasis to the breast. Sometimes you can get lymphomas in the breast, but that's not that common.
Oh, okay, so you're again focusing on the breast, but you're not resecting metastases at all. You just stick with the breast tissue.
No, so we remove the breast tissue. Now, the treatment for breast cancer is based on the stage of cancer. So if the cancer is stage 1 and above, then we will generally take out lymph nodes in the armpit also, because that's the first line where cancer can go and metastasize. So we will remove the 1 or 2 lymph nodes doing a procedure called the Sentinel node biopsy, where we take out just 1 or 2 nodes that are going to catch the cancer. And that's done for the stage 1 and above cancers. For early stage or stage 0 breast cancers, if we are doing a lumpectomy, then we don't take out lymph nodes. But when we are doing a mastectomy, then we'll take out lymph nodes. But that's generally the site of the resection. Now, if there is metastatic disease and it has spread to, say, only one site in one organ, then rarely they will try and excise it or do some kind of intra-arterial chemotherapy to try and resect the metastatic sites. But generally, we don't excise any sites of metastasis.
Okay. Well, so what do you see as the future of treatment in the next few years and then a bit longer term?
I think right now the future is super bright. The fact that we are now doing minimal surgery, minimally invasive biopsy techniques, very good cosmetic outcomes, it's fascinating. But the future also lies in genomics. The genes of the tumor will determine if a patient gets chemotherapy or not. The future lies in immunotherapy, because as you know that when you have a cancer cell in our body, the body's immune system wants to try and catch it and get rid of it, but the cancer cells develop mechanisms to avoid the immune system. So now we have these amazing immunotherapies out there which can actually make the cancer most visible to our immune system, and so we can kill the cancer that way. So immunotherapy, genomics, and the use of genetic information about a patient's genes will determine the future, I think, of breast cancer.
Okay. And then, Rabia, what's the best way for people to find out more about your work? Where can they go?
So I am affiliated with the West Suburban Medical Center. And if you go to their website, they'll have information about me. You can also find me at the Suburban Surgery Center, which is my group where I practice in Chicago, Elmwood Park. And that's the best way to get hold of me.
Okay. Well, very good. Rabia, thank you for coming. I'm really glad to speak to you.
Thank you.
If you like this podcast, please click the link in the description to subscribe and review us on iTunes.
You've been listening to the Finding Genius podcast with Richard Jacobs. If you like what you hear, be sure to review and subscribe to the Finding Genius podcast on iTunes or wherever you listen to podcasts. And want to be smarter than everybody else? Become a premium member at findinggeniuspodcast.com. This podcast is for information only. No advice of any kind is being given. Any action you take or don't take as a result of listening is your sole responsibility. Consult professionals when advice is needed.